Dr. Laith Al-Rabadi also spent some time in the Dave Salant lab. He currently is at Iowa. It's interesting. He did his medical training in Jordan. Excuse me?
I did my residency in Iowa, but I'm currently in Utah, University of Utah Health.
Oh, okay. Yeah, sorry. You did your training in Iowa and then went to Boston University Medical Center to do your nephrology fellowship and worked in Dave Salant's lab, where it looks like you picked up a very big interest in membranous as well. And now you're currently an assistant professor at Utah. Sorry about that. Go ahead.
Good. So thanks a lot for this introduction, and thanks a lot for Larry Bick and the prior speaker for the great discussions and the talks. It's a privilege to be here today. My name is Laith. I'm a nephrologist. I'm a clinician and I'm an investigator, and I love studying membranous nephropathy. Let me see if I can move my screen. No disclosure. So the things I'm going to be discussing. I'll discuss the evolvement of our understanding in membranous nephropathy in light of the new advances, the new discoveries, the new antigens, the new methods that led to those discoveries that Dr. Beck had alluded to. And I'm going to also discuss the possible transition towards an antigen-based approach as opposed to the primary-secondary approach, which has been the traditional classical one we have been using. Membranous nephropathy, as other speakers alluded to, autoimmune disease, rare disease, kidney-specific. The hallmark of membranous nephropathy is the finely granular, electron-dense subepithelial deposits with a significant amount of proteinuria in the absence of inflammatory involvement by immunohistopathology. Variable clinical response. Patients are usually treated with non-selective immunosuppressive therapy as we do with other autoimmune diseases. There's an article that came in Frontiers in Nephrology in 2005 with a title, Long Road, Well Traveled. I think for those who love membranous nephropathy, this is still very accurate and good description of membranous nephropathy. The initial question of answering up the pathogenesis, understanding the pathogens of membranous nephropathy, start with answering a key question. Where do immune complexes form? We know they will end up in the subepithelial space. We know it's described as subepithelial immune deposits, but where do they start? Where do they form to start with? Do they form in the circulation? Did the antigen and the antibody meet themselves in the circulation before they form soluble, small complexes that get trapped in the subepithelial space? Or is the antigen natively expressed in the podocyte, then attacked, targeted by circulating antibodies and for what we call in situ immune complexes? Or the process is completely different. Maybe the antigen is completely extrinsic, infection, malignancy, whatever it is. It got planted in the podocyte, trigger an immune response, then followed by attracting an antibody and formed again what we call in situ immune complexes. And what is better to understand the pathogenesis of membranous nephropathy than having an animal model? In our case, it's the Hayman nephritis model. 1959, rats injected with a proximal tubular brush border proteins, which act as an antigen, develop a similar clinical pathological pattern of membranous nephropathy in terms of significant proteinuria and subepithelial immune complexes. The target antigen, the brush border protein, turned out later to be myelin, as Dr. Beck has alluded to. Now, given that we're injecting with this protein, the prevailing thought at that time that there are actually those immune complexes form in the circulation before they go to the subepithelial space. However, further experiments done on bloodless glomeruli. So they try to provide the glomeruli from the blood and they inject them with the anti-myelin, with the anti-brush border protein, and they still develop the subepithelial space immune complexes, suggesting that maybe the antigen is natively expressed in the podocyte. These are all animal studies. The first proof of membranous nephropathy, or the pathogens of membranous nephropathy, came from clinical natures and cases of neonatal membranous nephropathy in newborn infants, when Dr. Ranko and his group described that mothers deficient in a neutral endopeptidase, which is known to be a podocyte protein, develop antibodies when they're pregnant with fetus, with normal fetus, and those antibodies cross the placenta and induce the typical membranous nephropathy in those newborn infants, which in months resolve. Again, supporting that membranous nephropathy is related to circulating antibodies against natively expressed antigen. This represents great examples of how astute observations and experiments of nature, if they encountered by scientists with a prepared mind, can lead to a lot of understanding and insight into the disease pathogenesis. This was crucial to identifying the major antigen in membranous nephropathy, PLA2R in majority of cases, followed by Th7A in majority of cases, as Dr. Larry Beck has discussed. How is that? And again, Dr. Beck has this may be a little bit redundant, so I'll try to be brief here. Knowing that's a podocyte antigen and using a human glomerular protein from kidneys deemed to be not good for donation, running this human glomerular protein, then incubated it with serum, reactive serum from patients with membranous nephropathy, looking for a clinical similar reactivity, similar pattern, cutting this corresponding region of the gel, and follow that by downstream proteomic approaches to identify the initial antigens, which is PLA2R and Th7A. However, 16% of the remaining antigens remain identified, and two causes for that. Given how rare they are, it's very possible that we have been depending on a common pattern of reactivity by Western blotting. But given how rare they are, it's not easy to find this similar pattern of reactivity. Moreover, we know that many patients who have membranous nephropathy may still have the immune complexes in the tissue. However, they are in immunologic remission. And even if we keep trying to find the antibody in the serum, we will fail. Hence, the new proteomic approaches that Dr. Beck also alluded to, laser capture microdissection, another method. And basically, we're switching from using the serum as our main target to looking at a tissue that may have enriched protein and will last and lag behind the immunologic remission. And basically what's done with laser microdissection, as described by the ME group and Dr. Sethi, it has been used before for amyloidosis and fibrillary disease, but here we're implementing it for membranous nephropathy with the understanding that those targeted antigens will be enriched. So basically we isolate the glomeruli and look for enriched protein, which can potentially be targeted antigen. It's important to mention that not all enriched protein are targeted antigens. There's going to be a lot of downstream proteomic validation to show that these enriched proteins are truly antigen. Dr. Kaz is going to talk about this later in her discussion. The other method developed by Arcana Laboratories is protein G immunoprecipitation. Basically, we elute the immune complex from the frozen tissue, and then we get rid of the antibodies, and then we send them whatever is remaining for mass spectrometry, looking for those enriched protein within those immune complexes, which also led to identifying more antigens. I'll be focusing at those antigens that are in what we think is a primary idiopathic membranous nephropathy, and those for lupus will be discussed by Dr. Kaza. NEL1 was the first antigen in membranous primary membranous nephropathy identified by laser capture microdissection, and supposed to be the second common after PLA2R and even more common than Th7A. Whenever you have a potential antigen, you want to show colocalization. You want to show that the IgG you're detecting by immunofluorescence do colocalize with your putative antigen, NEL1 in our case, and you can see green and red becoming yellow in this case, as opposed to different case like PLA2R case. What's unique about NEL1 is that the segmental distribution of the immune complexes, and here you can see segmental distribution of immune complexes, including some of the capillary loops, but sparing the other capillary loops. This was followed later by identifying SEMA3B, mostly in pediatric patients or very early adults, and then followed by protocol-adherent 7 in 2021, which has certain characteristics we're going to be talking about later. Okay. In the meantime, we were intrigued by a case, a 75-year-old female patient who presented with lower extremity edema, found to have 20 grams of protein, very low serum albumin, as you would expect, a granular pattern of IgG, subepithelial immune complexes by electron microscopy, negative staining for PLA2R, negative staining for TH7A. We have followed this patient very closely, and using serial serum sample, our longitudinal serum sample, our index case, were used to Western blot a human glomerular extract. And as you can see here in lane 1, a 50 kilodalton band was detected using serum sample from the active disease that declined and disappeared as our patient achieved clinical remission. This band was not detected using serum from a patient known to have anti-PLA2R antibodies. A region of gel it was excited from a gel identical to this Western blot and sent for our collaborators at the University of Louisville. And they come up with a candidate with a list of candidates. We pursued HTRA1, giving the right molecular weight and giving the antigenic characteristics of this protein. HTRA1 is known to be a tumor suppressor protein. It's studied in ophthalmology, oncology. We know little about this protein in nephrology. Now, the experiments have been using serum from a reactive patient. And the question is that, would they react with a recombinant protein as they react with the native protein? And here you can see paired lane of the recombinant protein and the human glomerular extract. And you can see the reactivity at the 50 kilodalton in our index case, and in another case. This reaction was absent in the 50 kilodalton region in serum taken from normal patient with TH7A, or patient with from PLA2R. Now, if you may wonder, why do you see only faint band when you use a human glomerular extract, but much stronger band when you use recombinant protein? That's basically because because HTRA1 is expressed at low level in the normal human glomerulus. So do circulating antibodies correlate with disease activity? And here we follow our patient closely, and you see that periods of a strong reactivity correlated with a high urine protein and low serum albumin. However, periods of weak reactivity correlated with low urine protein and high serum albumin. Now, we're switching from the traditional method to the novel methods. And this is a protein G immunoprecipitation performed in 3 patients that were suspected to have HTRA1. And you can see here our putative antigen, HTRA1, with a higher fold change and low p-value. Once you have this by mass spectrometry, once you have this by traditional method, you want to go back to the tissue and prove that by immunohistochemistry and immunofluorescence. And you can see this is HTRA1 case, and this is a PLA2R associated case. And you see the typical granular capillary wall staining in HTRA1 case as opposed to PLA2R case. Similar with immunohistochemistry, you see the strongest staining in the glomeruli, granular capillary staining, as opposed to PLA2R staining. You may see positive staining here in the tubules because we know HTRA1 is also expressed in the tubules. Do they co-localize? Dual immunofluorescence between IgG and HTRA1 did show co-localization in HTRA1 associated case as opposed to PLA2R associated case. Our cohort did include 3 cohorts: Utah cohort, Arcana Laboratories, and Oregon Health. 14 cases were identified. IgG4 was the predominant subclass. It's more common in the elderly, and it accounted for 4.2 from quadruple negative membranous nephropathy cases. Now, recently, and as has mentioned, every time you look in the literature right now, there's a new publications about either new antigens or new classifications. So this is a potential classification based on antigens. And one thing I want to mention, AD here stands for associated disease. You can see the significant overlap, even in antigen we tend to think as a primary antigen. You can see potential, whether it's coincidence or whether it's true association. Again, I think this is still a question that's not answered. The point is that you can see that the distinction between primary and secondary becoming more blurry right now. Let's use malignancy as an example. Even in PLA2R cases, in which we almost think this is almost certainly primary disease, there is a higher chance of incidence compared to the normal population. It's even higher in TH7A cases, which is up to 10%, and much higher in L1, in which in the Arcana laboratories by Dr. Kaza and Dr. Larson was found to be in 36% of the cases. So can we still call those antigens are antigens in primary membranous nephropathy? Or maybe it's the need to think more thoroughly and to think about more of antigen-based approach. The initial figure here came actually from Kidigo, and then Jonathan Hogan in his lecture was adding pieces there. And I thought it's really fun to keep adding pieces here, and we're going to keep adding more and more and more pieces. And just to shed a light in some characteristics, NEL1, 20% of PLA2R negative cases. Antibodies are found in some patients. And again, we talked about the association with malignancy. SIMA3B, more in pediatrics. You can see sometimes tubular basement membrane deposits. And what's interesting about those deposits, they don't stain for SIMA3B. So yes, there are deposits in conjunction with a membranous nephropathy, but they don't give you the same staining. Okay. And antibodies present in some cases. What is unique about this, they're only detected the recombinant protein in reducing cases, not in reducing, which represent more of the native status of the protein. HTRA1, 1 to 0.5%, IgG, more in IgG4, more in the elderly, and we detected antibodies in those patients we have been following closely, and we have samples from the active disease. Protocadherin, the last one by Mayo Grebe, or the most recent one, I don't think it's going to be the last one, accounts for 2% of all membranous nephropathy. IgG1 and IgG4 are the predominant forms. What's unique about it is that for the most part, it lacks complement deposition. Again, triggering another question. So if you don't have a complement deposition there, how did you end up with massive proteinuria? And there has been some cases with suspected secondary cause. This is what I think the clinician need to know. The subclasses, IgG1, segmental, more associated with malignancy in L1. SIMA3B, more in childhood. IgG1 is the predominant form. HTRA1, IgG4, more in the older population. Protocadherin 7, older population, lacking complement staining, IgG1 versus IgG4. Now, when a clinician may ask, why do I need to know? Why do we care? In some cases where a clinician, we are desperate for any clinical biomarker, any clinical indicators of the activity of the disease. I want to know if my patient is currently having immunologic active disease. I want to know if his disease is responding to my medication or not responding to my medication. Moreover, in the animal models, in the Hayman nephritis model, when they took fully advanced membranous nephropathy of kidneys from those rats and transplant them into normal host, which would represent the best, what is better example of treating the autoimmune disease than giving it a completely new milieu. Those immune complexes did resolve. However, the protein persisted for weeks or even months, which suggests that we may have some patients who may have still proteinuria, but they don't need immunosuppressive therapy while we're still giving them immunosuppressive therapy. Another factor is that knowing the associations we have with certain antigens and associations, maybe knowing a certain antigen will trigger the clinician to do more and thorough investigation in terms of looking for malignancies or other autoimmune diseases. Now let's look back at what we started. Our first discussion, are we dealing with in situ immune complex deposition, or are we dealing with, are we dealing with circulating immune complexes, and are those antigens natively expressed or are they extrinsic and exogenous? For PLA2R, TH7A, neutral endopeptidase, we think we know those are podocyte expressed surface protein forming in situ immune complexes and potentially activating the complement pathway. This may apply to SIMA3B and HTRA1, which we think are podocyte protein. But I'm not sure what we say about NEL1 and protocadherin 7, which we know they're not podocyte protein. Maybe we're dealing with different pathogenesis. Maybe those antigens are planted in the podocyte, and then they trigger the immune response. The planting mechanism is not unheard of. This has been reported in the pathogenic bovine serum. And what's interesting about those antigens, that they may be considered as molecular signatures of membranous nephropathy that may have a major impact in our patient care. I think those new antigens challenge the paradigm that we're dealing with uniform histologic pattern of membranous nephropathy, where we're dealing with different pathogenic process. And they challenge the paradigm that the antigen should always be a podocyte expressed protein. Maybe it's not. And one thing I found fun is that experiments in animals, that was in the 1960s, they used to inject them with bovine serum albumin to replicate a disease or to induce a disease similar to membranous nephropathy. And only in 2011, the French group did report that bovine serum is actually a true antigen in some cases of childhood membranous nephropathy. So are these antibodies pathogenic? Problems. Rats was the animal we used to work on to try to replicate and to study membranous nephropathy. Problem with rats, they don't express PLA2R, which make it even challenging to study the pathogenesis of anti-PLA2R in inducing the disease. Although we have a lot of evidence based on co-localization, based on correlation, that is still the pathogenic antibody. First example come from studying anti-THC7A, in which injecting mice actually with anti-THC7A induces proteinuria and immune complexes. But in many cases, they were deficient in complement factors. But again, there is discrepancy between a human and animal, and we don't know how we can compare them. So can the new antigens provide more insight? Is injecting mice with antibodies against those antigens can give us more insight into the pathogens of the disease? And can they tell us more whether targeting a certain organelles like endoplasmic reticulum trafficking or cytoskeleton will help having a precision medicine and personalized care? We already use CNIs, which we know that on top of the immunosuppressive therapy, they have a cytoskeleton stabilizing effect. And maybe every patient is different, and different treatments can be for different patients. Or maybe we have to be more granular and look at our favorite cells, the podocyte, and see if we can target certain proteins within podocytes in each patient to end up with more personalized medicine and to control their disease. So far, the research or what we discussed is that validating or revoking the Hayman nephritis model. But maybe as nephrologists, we have been so biased that our focus was in the kidneys, trying to replicate a disease in the kidneys. But maybe the whole process, and Dr. Beckman alluded to that, is triggered outside the kidney. The immune response may have it triggered outside the kidneys. It's worth mentioning that areas with more air pollution may have higher incidence of membranous nephropathy. And we know PLA2R is expressed in neutrophils and expressed in the lungs. And maybe the process starts completely outside of the kidney. That's not just a speculation, because an example we know of is the gallbladder cancer that has been associated with membranous nephropathy in New England Journal of Medicine, where they reported there is the strongest staining of the THC7A in the gallbladder tumor. Again, suggesting maybe that whole immune process triggering the immunity, they started outside of the kidney, and those antibodies went and found their way to the kidney and causes membranous nephropathy.